So this afternoon, what I was asked to do was to talk about vaccines and immune agents for patients with CLL. And I had 15 minutes, so that's not a lot of time to cover a big topic. And so what I thought I would do is just touch on some highlights, put things into perspective. So this is sort of I'm going to try to make this a general overview. It's a complicated topic. I think even doctors have a hard time putting their arms around the immune system and understanding immunology. So I'll try to make this something that's understandable, and please interrupt me if you have questions. So there are a number of defects in the immune system that are associated with CLL. Most of these arise because of the leukemic clone or the leukemic cells that are present, and the leukemic clone or the leukemia cells are very, very effective at confusing the immune system and causing abnormalities and confusing cells that should normally function normally but don't function normally because they've had some interaction with these malignant B cells. So there are a number of different abnormalities that have been identified and characterized in patients with CLL, and those are what relate to and increase the patient's risk for infections. So that's the major area that we have problems with and that we need to work on, is reducing the number of infections. And patients have an increase in infections and certain types of infections even before they receive treatment. And our treatments tend to be also immunosuppressive and can make that immunosuppression and immune dysfunction worse. So we really need to work on ways to correct the immune defects that patients have because the disease is there, and also to help patients reconstitute their normal immune system and immune function once they've been treated and they're in remission. Because as I mentioned, a lot of the treatments that we use deplete not only the leukemia cell, but also deplete normal cells of the immune system. Because basically the leukemic cell, the leukemic clone, is or was an immune cell. And so the treatments that we use are also effective at suppressing the normal immune system. This slide just highlights the different cells and some of the abnormalities that have been characterized. So there are a number of different cell types that comprise the immune system. We have B cells that make antibodies. We have T cells that help fight off infections like viruses. We have NK cells that also help fight off viral infections. Neutrophils, which help fight off bacterial infections. And all of these cells have been characterized in patients with CLL, and there have been abnormalities demonstrated in all of these different cells. Now these are normal cells, they're not malignant cells, but because patients have the leukemic clone circulating, that leukemic clone can cause abnormalities in the normal function of these otherwise normal cells. One of the things that we had worked on a while ago was T cells and trying to correct the defects in T cells. And in fact, if you take T cells from a patient with CLL, you can demonstrate that they're abnormal when you take them right away from the patient. But if you grow them in the laboratory, you can pretty much correct all of the abnormalities that were present when they were in the patient. So one of the approaches that we have tried in the past is to take T cells from patients, expand them in the laboratory and activate them, and then to give them back to the patient in order to reconstitute their immune system. We have a study that is ongoing with that strategy, and I think there are plans to continue that activity. Dr. Gribben has done a lot of work in terms of characterizing T cells, which have a lot of different abnormalities in them, and that is in part why patients are at increased risk for infection and immune compromise. The other aspect to the immune system isn't just the risk for infection and the propensity to develop infections for patients with CLL. Also, patients with CLL have a propensity to develop autoimmune problems where they destroy their own red blood cells, they destroy their own platelets, and that's also part of this immune dysregulation or disruption of the immune system that is brought on by the presence of the leukemia cells. And it also relates to what the leukemic cells can do to altering the normal T cell function. I'm going to skip over these detailed slides. These detailed slides just go over some of the infections that patients get before treatment and with treatment. A couple topics that I wanted to touch on is some of the things that we can do for patients to minimize or reduce their risk for infections and infectious complications. So the first topic is things that we do for patients who are going on treatment to protect them from developing infections. The second part that I'm going to talk about is replacing some of the things that are missing from the immune system for patients with CLL, particularly giving back immunoglobulin or antibody as a strategy to reduce risk for infection. And then the third area that I want to talk about is vaccines and what we currently do to vaccinate patients to reduce their risk for infections. So this slide just highlights things that I think are important to think about in terms of patients who are going on treatment, either their first treatment or retreatment for patients who have been in remission and their disease has come back. Herpes viruses are important viruses that everybody here has been exposed to, and in patients, individuals who have a suppressed immune system, those viruses can become reactivated. Those are viruses that cause canker sores and also virus that causes chickenpox and resides dormant in nerves and can become reactivated to give you a shingles outbreak. So the herpes viruses are important. Those can be reactivated in patients getting treatments that we give. So we usually will give prophylaxis for these types of viruses when patients go on treatment, and particularly in patients who have been previously treated who are getting retreated. So acyclovir or valacyclovir or Valtrex are two drugs that we use as prophylaxis to minimize or reduce the risk for those viruses being reactivated. Pneumocystis is a protozoa that can become reactivated or can develop into an infection in patients who are getting treated. It's more common in patients who have been previously treated who are getting retreated. So a lot of times we will use a drug called Bactrim and put patients on that drug to suppress that infection from occurring in individuals who are getting retreated who have previously received treatment. And then there's another virus that's usually dormant and is held in a quiescent stage by the immune system called cytomegalovirus or CMV. That virus can be reactivated particularly in patients who are getting an antibody called alemtuzumab or Campath. So there's a couple of things that we can do for those patients. We can monitor for viral reactivation, and we have done, Susan O'Brien did a study at MD Anderson showing that patients could receive, who received valganciclovir, which is an antiviral agent, that would suppress the risk or reduce the risk for reactivation of CMV. So those are some of the things that we do for prophylaxis for patients to reduce their risk for infection. We do those generally in patients who are receiving treatment, either first treatment or salvage treatment. The only other time that I will use viral prophylaxis in a patient who isn't getting treated is in a patient who has had recurrent zoster or shingles outbreaks. I will use Valtrex to suppress reactivation of that virus, even if they're not getting treated, if they've had problems with recurrent reactivation. The next topic was antibody levels. So B cells make antibodies. CLL cells are B cells, but they don't make antibody. They are associated with reduction in normal B cell counts. So if you measure normal B cells in patients with CLL, they will be reduced, and they're even lower in individuals who have been treated. And that's also associated with a reduction in antibody levels, and that predisposes individuals to infections, bacterial infections, and particularly infections in the respiratory tract, sinuses and lungs. So one approach that can be taken to correct that is to replace that, and so we have gamma globulin that is available. There have been studies that have shown that you can reduce the risk for recurrent infections in patients who have had significant infections if you give intermittent IVIG or antibody replacement. So that's another strategy that we can use. to correct that defect in the immune system and reduce the risk for infection. That doesn't change overall survival, but certainly it has been associated and has been demonstrated to reduce the risk for recurrent infections in patients who have had significant infections and who have low antibody levels. So that's another strategy. One interesting finding that Dr. Ferrioli found on our Revlimid study was, interestingly, that this drug, Revlimid, which is an immune modulating molecule, in our study, when patients received Revlimid alone, they had improvement in their antibody levels. And that had never been shown for any treatment before.